Good morning, everybody, and thank you for joining as always. As always, we'll say we're just kind of slowly giving a moment for everybody to join the grand rounds. I'm really always nice to say that we don't have many updates. We will, as I've mentioned before, we'll continue to have updates as relevant to anything that is important, particularly the pandemic and updates and variants and whatnot. But we just don't have any updates right now because there's nothing pressing to say, which is we were just talking about how no news is always good news. But as always, if you do have something that you would like to see updated upon, please let us know. And I'm happy to make sure that we have the right person to provide those updates about it. So we'll keep having various updates about various things in the following weeks, but nothing really today, which is wonderful and gives us more time for our presenter we're very excited to hear from today. Before we have our person who's going to introduce our presenter, I do want to turn it over to Dr. Harmon, who will just briefly mention this is a special lectureship today and tell us more about that. She's also helpful in organizing this in the first place. So Dr. Harmon, I'll turn it over to you. Thanks a lot.
Thanks so much, Dr. Rosdalga. So I just wanted to say a few words about the Jonathan J. King Lectureship. It is a lectureship that is part of the Stanford Center for Biomedical Ethics and has essentially an endowed lecture in honor of Dr. King, who is a computer scientist here at Stanford and who died of cancer 32 years ago. And this lectureship is held in his honor. In his last weeks, he actually taught the medical students and talked about his illness and imparted kind of a message of the importance of humanism in medicine, in healthcare. And so the lectureship was born, and we've been able to bring wonderful medical humanists over the years. Dr. Carrie Brenner is the chair of the lectureship committee and invited Dr. Aronson this year. And so the King Lecture is a public and open lecture. It was held last evening, and we're just excited to have Dr. Aronson also give grand rounds this morning. Dr. Aronson will be introduced by our very own Dr. Deb Cotto, who is our section chief for geriatric research in the Division of Primary Care and Population Health. So I will pass it to Dr. Cotto.
Well, thank you, Stephanie. It is an absolute pleasure to be able to introduce Dr. Louise Aronson. She and I go back, I think I counted 25 years. And one of my memories of being a fellow, maybe the first fellow at UCSF when the fellowship got revitalized, was rooming together at maybe my first American Geriatric Society meeting. And I think if you told us back then that we would be where we are here now, we both probably would have fallen off our chairs. Anyway, she is a leading geriatrician, writer, educator, professor of medicine at UCSF, and the author of the New York Times bestseller and Pulitzer Prize finalist book entitled Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. She is a graduate of Harvard Medical School and has received the Gold Professorship in Humanism in Medicine, the California Home Care Physician of the Year Award, and the American Geriatric Society Clinician Teacher of the Year Award. In addition to her continued clinical practice in geriatrics outpatient medicine, she currently leads the Age Self-Care Program and serves as an advisor to the state of California on COVID-19 in elders. She has multiple writing credits that include the New York Times, Atlantic, Washington Post, JAMA, Lancet, and the New England Journal of Medicine. It is, we so much look forward to hearing what you have to say today. Thanks, Louise.
Thanks, Deb. It's funny to think of all those years ago. Well, thank you for having me. I sort of debated what to do here, and there are so many ways to go. And it shifted a little bit. So it's interesting that you don't have pandemic updates. we go back and forth at UCSF with that, and we seem to be entering this phase where there's still a pandemic for some people and not a pandemic for others. I was in the UK last week, actually, and there's almost no masks. And so we're at this point where I think we might have the breathing room to learn from pandemic a little bit. And I'm going to take that lens on what I'd like to talk to you about in terms of clinical and conceptual and future approaches to aging and the care of older patients. So pearls will be lessons from the pandemic. Paradigms will be just a few things that I feel are different about geriatrics, and that aren't, it helps to have the years of additional training and to know all the science and clinical medicine. But I think even understanding the paradigms can really transform a person's care. And if you follow the evidence, that would actually improve health outcomes. And then a few things that I think might be game changers coming down the line. Deb mentioned that I have this history with humanities. So I'm going to give you a brief history of geriatrics in just 3 slides, because I know for some people, this is like their idea of hell, having a history lesson all these years after school. But the term was actually coined in 1909, so over a century ago. And what Ignaz Nasher, who was the head of the health department in New York City, said was that he hoped to cover the same field that is covered in old age, that is covered by the term pediatrics in childhood, to emphasize the necessity of considering senility, by which he meant old age, not dementia, and its disease apart from maturity, by which he meant adulthood, and assign it a separate place in medicine. Now, this has not happened. But I think his impetus holds, and it may be why pediatrics has persisted as long and successfully as it has. One of the first people to really outline what it meant was a surgeon named Marjorie Warren. So she trained as a surgeon, and being one of the few female surgeons in the UK, was logically assigned to run a sort of aftercare ward for elders where no surgery was required. And she went onto this ward, which was dark and had people in their beds, and realized a few things. One is that old people deserve medical care. Good care begins with comprehensive assessment. So what she found on that ward was that there were some people who were bedbound, and there were a lot of people who were just fine and were being held essentially hostage for reasons that she could not figure out. And the largest group of people were people who could be fully rehabilitated and sent home, which is what she did, but they hadn't been assessed for that potential or given any of the treatments. And so she concluded that many chronic conditions are treatable, that team-based rehabilitation can be transformative, that the physical environment impacts health a lot. They were basically kept as prisoners are in solitary confinement without windows or light or color. Everyone needs purpose and engagement. Part of her rehab was putting people to work and giving them a raison d'etre. And old people need dedicated units in hospitals. So again, some things change and some things don't. In 2022, what do we have? We have age-friendly health systems. And this has been a terrific innovation over recent years. And it basically just asks that when we're caring for an older person, and what do I even mean by that? It depends on who you are, right? If you are a person with less access to care, or who is liable to get less good care because of your income, your race, where you live in this country, you may be old or geriatric in your 50s. This has been found in homeless populations, incarcerated populations, and people who have been formerly either of those. And you may not be old until your 70s if you are a very privileged person. But this is a framework which is very limited and very helpful simultaneously. Because a more age-friendly health system is our children's hospitals, yours and ours at UCSF, which are beautiful examples of how the environment can foster healing and can also encourage hope and excitement among both patients and clinicians. So the lessons from the pandemic, with that sort of historical context of, nothing has changed, everything has changed. You know, in the time since Nasher coined the word, we have extended longevity by decades, and when many more people live into old age, but we still haven't put his lessons or Marjorie Warren's lessons into effect as much as we should. The pandemic kind of illustrated how this is and is not working. So does age matter? Absolutely. We saw this early on, actually, the data from China and Spain and Italy showing that risk began in middle age and then went steadily upward with old age. And that kind of makes sense to us intuitively, except for biology wasn't the only player. So for instance, in the United States, this was early data on mortality differences in people, all of whom were ages 75 to 84. And if you look at the rate differences in death, you know, Blacks 889, Latinx 535, Native Americans 205, Asian and Pacific Islanders 146. And about a year after this, there was a JAMA study of Medicare beneficiaries and risk of death. And it turned out that the risk of death had to do with where you went for your care, and that it correlated also with your risk of death being an older person of color if you had a ruptured appendix, if you had a heart attack, if you had a stroke. So yes, age matters, and also where you get care matters, and who you are matters in ways that clearly it should not. I believe strongly that old age is an intersectional DEI opportunity, and it comes all kinds of ways. We've discussed race, but gender is also a player here. You know, from one of my favorite medical journals, the New York Times, why aren't more women working? They're caring for parents. But this is a double DEI issue, right? So the people who can afford to not work are caring for their patients. And the poorest people, the people whose parents are more likely to be having accelerated aging, probably have to work themselves to survive. So their parents are going into nursing homes, usually not the nicest ones. And we'll see in a minute what happens when that takes place. So just levels of harm. The other thing is during pandemic, we saw this certainly among our faculty, no doubt among yours, that a lot of the people who stopped working or needed time off or took early retirement were either younger women caring for their children and teaching their children at home, or middle-aged and older women taking care of parents. So they're losing the present income, but also the retirement benefits. And then if you look at nursing homes, that way more women than men, and that is more so with age. But look on the right at who works in nursing homes, 90% female, disproportionately people of color, almost all poor since they are not paid a living wage. So we say we are a country of family values, and yet when members of our family require care, we don't actually pay people to do that work that's, you know, so hard for anybody. Age matters very clearly. We see this again in this data, now over a year old. The numbers, you know, change over time, but this was sort of when vaccinations had made things better. These numbers were worse 6 months earlier. And still there was disproportional increases in risk of hospitalization and death, no surprise to anyone. But it turns out a huge percentage of those deaths were what one might reasonably call avoidable. Policies and priorities matter. Literally, the federal government did not count pre-May COVID deaths from facilities. This is politics. They've since been counted, and there were 16,000 uncounted deaths. So imagine a life in which you are quite literally not counted by your federal government. One could digress there, but I'm not going to. So nursing home safety during the PPE shortages, we knew before this virus hit that the highest risk people were the oldest and frailest, and yet those places where they are cared for were not prioritized for PPE. They couldn't even get testing. Some places were having trouble getting testing a year into the pandemic. And then the national effort to vaccinate nursing homes also came off to a slow start. Why? Because the people making the policies didn't realize that nursing homes already have relationships with pharmacies. And so they went to Walgreens and CVS instead, and they actually didn't even know how to consent people in these facilities. Now, I'm talking a lot about nursing homes now, and there is a reason for that. Only 2 to 4% of older Americans live in these facilities, but it is really one of the only contexts in which we gather data on old people, unless they're in a hospital. The federal government also made some decisions that probably quite literally killed people. So they waived training requirements in a pandemic in facilities where training penalties are ubiquitous across states, and yet the penalties are so small that places can be literally killing people and retain their license unless a journalist, happens to make a big fuss. They suspended all inspections, so the poor, underpaid, mostly female, mostly people of color workforce was expected to go in, but the people who would have inspected and might have had the skills training, the RN degree, to teach these people how to safely use their PPE, et cetera, did not have to go in. And in the state of California, it was about a year and a half before they returned. So what were the consequences of this? Yes, people were older and frailer and more vulnerable, but you can see how policies contributed to what many have called a slaughter. Nearly 1/3 of coronavirus deaths were linked to nursing homes as of April 2021. It turned out that in nursing homes, 1 in 10 people died. Now, you might say to yourself, well, how many die in a regular year? It is considerably less than that. It's obviously more than for the rest of us. But this was an exponential increase, and less so, but similarly in assisted living and other facilities. And California, has been better than many states in dealing with this, but also failed on nursing homes, and there is a major review underway. Among the reasons for this, this was an article from New York Magazine, which talked about how the governors of New York and New Jersey in the very first wave, older people take a little longer to get better. We all know that as clinicians. And so when people weren't getting better and they needed the hospital beds, they moved them into nursing homes. These were people who were community dwelling. So they sent them with their COVID into nursing homes that did not have PPE or testing ability and had no experience with segregating people with infectious diseases. So literally policies introduced infection. So yes, older people are more vulnerable, and there are all these ways we, as part of the healthcare system, can decrease that vulnerability if we choose to do so. Striking racial divide in how COVID hit nursing homes, this is very well documented. So again, the intersectionality here. And then a patient of mine said this to me at one point. She's in her 80s, still working, and says, why doesn't anybody ever talk about the 96% of older people who don't live in nursing homes? What are we supposed to be doing? First, they say we're at really high risk, and now they're saying we're the same as everyone else, which isn't. And this is a woman who has not a college degree, but a lot of book learning. And she was listening to the UCSF town halls every week. And she said, I've been going to these town halls for a year, and there was one panel on nursing homes, really vulnerable people, and there's been no mention of people like me. Prioritization by risk actually matters. So when the US government did this, which was with vaccination, not with PPE testing, diagnostic algorithms, treatment algorithms, vaccine and treatment trials, harm reduction efforts, or public information campaigns, and I'll show you about that in a minute, but when they did it with vaccination, the older and frailer people began dying at lower levels than the middle-aged people. So when prioritized, we see better health outcomes. Again, something about intersectional harms. This was an article about emergency room use, and what they were finding was when care partners weren't allowed in, and at many hospitals, care partners were allowed in for children, for women giving birth, and for people dying. Interestingly, it was usually the moment you were dying, so your family knew, were there for that, but you didn't actually know they were there. So again, a not great understanding of the end of life, but very few, and it's still exceptional, would allow in care partners of people who were having delirium, or people with dementia, people for whom that grounding by a familiar face and voice can be transformational. Just remember that delirium's morbidity and mortality is akin to sepsis. But what they found in this study was sometimes people could talk their way in. And who were those people? Those were people with more education, people with more social influence, social capital, mostly white people. And if you spoke Spanish, for example, as your primary language, or Tagalog or Hindi or anything else, you were much less likely to be able to get in to help your older parent. Atypical presentations, I sort of did this not so that you could possibly read it, but just to show that there is this huge literature on atypical presentations in COVID. Now, is it for everybody? If you're a healthy 70-year-old, no, you're going to present with so-called typical symptoms. But if you're over 80, if you're frail and over 60, atypical presentations in different studies ranged from 30 to 60%. And so are they atypical if you're in one of those categories? Probably not. And this was something we, at least in geriatrics, had heard about primarily from Italy and China by March of 2020. There were also studies like this in VA and community nursing homes showing that the temperature cutoff often missed fevers in older adults whose set point may be lower. And so if you're not incorporating data, if you're not practicing evidence-based medicine, and we've known about different temperature set points, so that often the delta is more important than the absolute number, you're going to miss people in early screening. And we know for all people, the earlier you institute treatment, the better the outcomes for most conditions. And certainly if you're frail, you're at higher risk for complications. So a later diagnosis is more likely to lead to a bad outcome. This was an emergency department study, I think from Boston. And what it showed was of the 817 patients, and the cutoff was, relatively low, depending on who you are in the audience, 65 years or older. 37% had no typical COVID symptoms or signs. I don't know what Stanford did, but at UCSF, we tried to advocate for this evidence-based approach. And we, throughout the pandemic, have only had adult and pediatric algorithms, which again means that if someone was confused, now they get tested. But early on when testing was tough, they didn't get tested. If they had a fall, they didn't get tested. If they just felt weak, they didn't get tested. And that meant they got much more sick. And when they came in, they were directed more towards palliative care, which is a wonderful thing and very appropriate in some circumstances. But how much were the care flow patterns part of the problem versus biology? There's also a different national response to atypical presentations. The inflammatory syndrome in children got a lot of attention, even though the cases were in the hundreds, whereas the atypical symptoms in older patients, which were in the hundreds of thousands, got much less attention. And that sort of speaks to who counts and what counts, right? Because the inflammatory syndrome had all this exciting biology, whereas older adults' atypical symptoms, that's actually not news. We've known about atypical symptoms for decades, if not millennia. So maybe a little less sexy from a scientific standpoint. The Ontario Human Rights Commission pre-pandemic noted something that I think is apt, and this isn't because it's a competition among disadvantages, but they noted that from a human rights perspective, there is a lack of sense of moral opprobrium linked to age discrimination, which in comparable circumstances would generate outrage if the ground of discrimination were, say, race, sex, or disability. I think that's maybe especially true in more woke areas like the Bay Area, and not to say that we do any of those other things as well as we might. From a research perspective, there is both good news and bad news. Because of the NIH mandate to include older adults in research that impacts them, there were more older adults included in vaccine and treatment trials than used to be the case, if you can say anything is comparable to pandemic research, but in potentially comparable studies prior to pandemic. And yet there remain this exclusion, sometimes on the basis of age and sometimes on the basis of comorbidities, which are ubiquitous in older age, which then means that your treatment results may not apply to your patients not a helpful approach. I think one of the lessons that we keep learning is that until funding for research includes enough funding and requirements for attention to include diverse populations in that research, it will never apply as effectively to the people at highest risk as it might. Really different standards for safety and efficacy. We saw that it took longer to get vaccines for children and then for very young children. By contrast, residents of long-term care facilities were among the very first, along with all of us, to get vaccines. Residents from long-term care facilities and people equally frail living in the community, of which there are many, many more, were not included in the safety and efficacy trials. So the one group of people in whom safety and efficacy was never established until the real world setting was basically people over 75 and certainly people much older than that. Now, did we get hugely lucky with that? We did, but I'm not sure luck is a great scientific or policy strategy. So I would just argue that evidence-based medicine matters at all ages. And it's generally good to think about, here's my patient. Does the evidence I'm using to make this decision include people in this age group with these comorbidities and with this functional status? Access to care also matters. There have been a few different studies, but this was a case series from Mount Sinai Health System, and I chose this because this is considered one of the more age-friendly health systems. And yet they found that compared with people under age 55 years old, those ages 55 to 64 were half as likely to be admitted to the ICU. Now, as a person between the ages of 55 and 64, I find this particularly concerning, but maybe that also had to do with the multi-morbidity of the people who were in that age category, who are the people most likely to be in the hospital. And all of that again brings us back to the social determinants of health, the opportunities and lack of opportunities that lead to diabetes and hypertension and all these chronic conditions, the multi-morbidity, which we know has been critical to those middle-aged adults who end up hospitalized or dying. They also noted that those 85 years and older were a quarter as likely to be admitted to the ICU. Now, is that good or bad? Right? It's complicated. The authors conclude that whereas these findings may be explained by the patient and or family preferences, right? If I'm 89 and I have pretty bad COVID, I may choose palliative care, and that may be the best choice for me in any number of ways. But they say we cannot exclude the possibility that clinicians may have made informal triage decisions regarding scarce ICU beds based largely on a patient's age. And this also harkens back to a pre-pandemic literature, which shows that if you correct for a functional status, prognosis, multimorbidities, a lower risk older person will get less good care than a much higher risk younger person because of biases that are ubiquitous. So it's not like, oh, I'm a geriatrician, I'm not ageist, and you're not, so you are. This is something we know is a universal prejudice and something we all have to work on. And why is there this complicatedness? Because age matters, right? How old you are and what your functional status was before matters. And it may be a better decision not to go to the hospital or not to go to the ICU. And it may be an ageist decision. We also saw yet again that old people are a highly varied group. And some of this just stands to logic. 65 doesn't equal 85, doesn't equal 105. But when the pandemic began, we were so worried about older people sheltering in place and the epidemics of loneliness and social isolation, which have such high morbidity and mortality, more so than some of the differences in blood sugar or lipids or hypertension that we spend so much time chasing. So there were people who had increased loneliness. They tended to have a history of depression or anxiety. have low emotional coping skills, and so smaller social networks and higher functional needs. But actually, the majority of older adults did far better than children and people in their 20s. They adapted. Resiliency, and you learn to adapt by adapting, and the longer you've lived, the more you've had to adapt. Technology access and ability made a huge difference. High tech, low cost care workers really have been shown to be helpful with depressed, low income elders. And clearly there was just more resiliency, and we just keep seeing article and article about this, which isn't to say, and this is the variability thing, right? There are the high risk people, kind of like the nursing home residents, and there are the low risk people. So to talk about old people or geriatric patients is kind of like saying you're going to take the same approach to, a 1-year-old and an 18-year-old. Messaging also matters. This was from Time magazine, which admittedly doesn't have the influence it once did, but the road to recovery, how targeted lockdowns for seniors can help the US reopen. And I think there's an irony here where US, of course, also spells us. There's us and there's seniors. Most of us will become seniors, so this doesn't seem like a great strategy. It also makes very little sense in the era of harm reduction when we know that lack of movement, lack of social stimulation accelerate aging, physical and cognitive decline. Messaging matters a lot, and this was problematic at the federal level. The CDC for the first, I think, 15 months of pandemic had this list, which was basically an example of what I call adultism. So sort of things you need to know, symptoms, testing, etc. They did have a pullout for children and teens with 9 different items, which is terrific. So recognizing that they were different. But at this point, 82% of deaths were in older people. So we have a pullout by age, but we don't actually have older people. If you looked, they were somewhat buried under people at increased risk, but there were far fewer sub-menu items, not really thinking across the functional or health statuses or living situations of older people. And even more recently, older adults are lumped in. They're both split because there's people with disabilities and there's people with dementia, but they're mixed in, and their settings, adult day services, but they're kind of mixed in with people who are also at increased risk, but at much lower increased risk. And obviously, this is not a zero-sum game. There are so many ways to be at risk. The harms to children, for example, have been less from infection and more from infection control. But again, we need to meet each population where it's at and look at its needs. There is hope. The CDC director has prioritized public health communications. I'm not sure she means by this what I mean by this, but I do think it offers a potential route to better messaging about pandemic for all of us. For those working in inpatient and ER settings, the overwhelm, the tragedy, was incredible. And imagine if more effective messaging or policies could have drastically lowered the number of people who were coming in. And in the outpatient setting, there was precious little guidance or prioritization of the things that might have been done more effectively to prevent some of the secondary harms like untreated cancers, neglected screening, et cetera. I want to end, just noting this section by noting that positive outcomes tend to get less attention, and just focusing, on just a handful of the many articles starting in November of 2020, which really recognized that, hey, they're actually doing much better than many other groups. Okay, I'm going to more quickly go through paradigms and game changers with that sort of as a setting, because what pandemic showed is that things we've been talking about for a long time are are still all apt and yet not really included in the health system in the way they could be, in ways that would lower costs and improve lives for patients, but also for clinicians. The rates of burnout, as you all know, are off the charts and causing further harms to our system and patients. So risks and benefits, oh, I didn't do a very good job with that, sorry, really vary by age. When we are looking at a patient, it is said that if you have a 2-year-old without a serious illness or major disability, they're the same worldwide. Similarly, for 22-year-olds, you get up to 42, you start seeing more variability. By 62, there's considerable variability. And by 82, you have some of those people in nursing homes, who are tragically sitting in their wheelchair, not doing much. And you have Nancy Pelosi running the House of Representatives. So the range is huge, and the age as a number is useful, but not as useful as we use it to be. Not as useful as it is earlier in life. So thinking about health, are there comorbidities, and what are they? Because a little bit of arthritis, a little bit of treated hypothyroidism, really different, from, CKD3, B, and congestive heart failure, and, any number of other things. We all know that intuitively, but it must go into the equation of evaluation. The next thing is function, because risk for hospital outcomes, risk for hospitalization, risk for hospital outcomes has a whole lot more to do with functional status than with admitting diagnosis or comorbidities. Things like, can you walk up a flight of stairs? What is your grip strength? And those sound not medical to many people. But so I would again push that if we're practicing evidence-based medicine, we can't be doing that selectively. If that's the evidence, shouldn't that be an intake assessment? Shouldn't it inform what kind of care we're offering this person? Because they might have very different requirements based on their functional status, and their risk might be different. And what happens will then, what you're going to offer as treatments should vary. And that correlates again with life expectancy. Nancy Pelosi's life expectancy is one thing, and the person in the nursing home is very different. And those may be different, to the tune of 10, 15, 18, 20 years. And that weighs in on the risks and benefits of treatments of all sorts. And then there are the patient preferences, which are key. And more so as we age, because as your horizon of life closes, we know two things. One is that people are much more clear on what they value. And the second is, again, about these risks and benefits. The risks go up and the benefits are going down, particularly if they're longer term risks. A second geriatric sort of paradigmatic difference is a real focus on harms. So much of medicine is prescribing, and we think much more about de-prescribing. If you look at adverse drug reactions, they are hugely disproportionately among the elderly. That has to do with the elderly not being included in the trials because of their comorbidities. There is a famous article from the Annals over 10 years ago now, taking a relatively healthy 75-year-old woman with some hypertension and hypothyroidism and maybe a slightly elevated cholesterol and some arthritis. And there were literally 35 things she was supposed to do every day if you followed the guidelines, because the guidelines didn't really think about a person like her. So thinking about harms, is this medicine necessary? What are the drug interactions among these medications? Why is the person still on this medication? What is the data for this medication, given this person's muscle to fat ratio, given this person's creatinine clearance? These things can hugely lower iatrogenic problems. We also see systems to get people seen more effectively in emergency departments and to focus on some of the reasons they're coming in. And this is a paradigm also where we think not just about the person, but about their social and physical environments, because sometimes you can change the person, hip replacements, knee replacements, those are fantastic things. And sometimes we don't have those options, but the right physical environment can make the difference between a person being handicapped or not, even if they have a disability. There's also just tremendous data on hospitals and ways of avoiding things like delirium. And we're doing so much better on that. But does it get the attention that its equal sepsis does? Not so much. And maybe that's because it's a little less medication focused, except for the all that Peter Provost data on sepsis and changing the systems of care really make a difference. So could we do this for older adults? We actually have an extensive literature from little journals like the New England Journal and JAMA that we could be applying more effectively if we thought as much about harms of care as benefits. Co-management leads to better care and lower costs. There's so many examples of this. People with cancer, geriatric, orthopedic co-management. Different systems of care make a difference, and settings of care make a difference. And we think more about that. There are all kinds of team-based innovations, and you may or may not have heard of these. I'm not going to go into too much detail, but there is POSH, GRACE, and ACE. These are sort of the geriatric acronyms, not quite as household world-ish as the cardiology ones. But these are things that literally are proven to be high value, low cost, and team-based, and they don't get as widely adopted as they would based on the data. Interesting to ask ourselves why that might be. And then I think we have some important questions to ask ourselves about end-of-life care. If you are 96 and you have trouble hearing and seeing and moving and you're incontinent and your brain doesn't work well, and it's hard for you to find purpose or connection in your life because of all those problems, is that different than being a person with disability at age 20? If you have cancer at age 89, is that different than having cancer at age 49? These are tough questions, right? Because it's a slippery slope. And the ableism that is part of ageism can get us into trouble here. But I think we don't get to answers if we don't begin asking questions. It is probably no surprise that the sort of poster patients for medical aid in dying and similar are generally young people with cancer. All right, and I'm going to close us out with just a few thoughts about a 21st century vision for care of older patients. Obviously, a big one would be applying some of these really different paradigms more consistently and really following the evidence base. And the good news is the evidence base on care of people in their 70s, 80s, and 90s is increasing all the time, and was in fact increasing prior to the NIH mandate for their inclusion in studies, which I just have to say happened 30 years after the mandate to include women and people of color, and 20 years after the mandate to include children in studies of drugs and treatments that would be applied to them. So I think geroscience is a game changer akin to precision medicine. And obviously there's some overlap here, but what exactly do I mean by that? There are a variety of approaches. On the left, you see an ape who was fed a normal diet and has, sort of more sunken features and thinning of its hair and some changes in its skin. And this is an equally old, 26, I think, year-old ape on the right, who was fed a healthy, somewhat calorie-restricted diet. Now, calorie restriction, not so popular, but one of the hopes of geroscience is to find molecules or mechanisms within the body that can mimic those effects without people having to eat less. I would like to think that the approaches are not necessarily mutually exclusive, that we could have fewer processed foods and fewer food deserts, and that might be helpful as well. But geroscience really, sorry, I didn't mean to do that. Of this fancy new mouse. Geroscience. So really it's studying the fundamental mechanisms of aging. Some of these approaches are said to would save more lives, and not just in terms of longevity, but in terms of functional status and health conditions, delaying them. So would be, if they realize their promise, they would be more effective than eliminating heart disease, cancer, and diabetes simultaneously. And you can see from the graph in the lower right that it's basically sort of shifting that curve towards the right and downward. You know, do we still grow old and die? Yes, we do. That's probably necessary. Some people don't believe that. But this is really a conceptual difference in that it's a departure from the one disease at a time approach. Many of the risk factors for the most common diseases are the same and have to do with changes in mitochondria, in nutrient sensing, have to do with changes with age like cellular senescence and stem cell exhaustion, have to do with probably environmentally and stress mediated attrition in telomeres or epigenetic changes. It's a pretty exciting area, and we don't tend to align it with aging or with medical education as much as we might. Wow, I'm really messing up my mouse here, sorry. There are exciting studies underway, you know, metformin to delay the onset of multiple chronic conditions. There's also been studies of like metformin given to healthy older adults for a month before their flu vaccine, and the flu vaccine has longer and better efficacy. You can, of course, always just give them the four strength flu vaccine. That might make more sense, more cost effective. Young mesenchymal cell infusions to treat frailty, so that cellular senescence, you replace those cells with more vital cells. And then rapamycin has been shown actually to prevent respiratory infections in frail elderly. And this is all about, again, shifting that curve to the right, compressing the period of morbidity and disability and dependence. But I always, when giving these talks, feel like I have to point out something really important, that we could do this in a much more cost-effective way, because exercise does all these things. And imagine if part of your insurance benefits was, you know, membership to a gym, where you could get exercise, even supervised exercise, because gyms can handle lots of people simultaneously. It is considerably more cost effective, and it has benefits for mental health, physical health, and aging. So, you know, yes, geroscience will probably be a game changer because that's what's funded, but we have some tools already. Age experts, including geriatricians, are often part of the problem. Apologies to my colleagues, although I discussed this with them yesterday. So the city of Boston's anti-ageism campaign include this from Vinny, age 83. I'm a longtime boxer. I can still pack a punch, you know, et cetera. I'm many things, but frail isn't one of them. But isn't that creating a world that when he becomes frail, and let's look at Vinny, it's not that far off, right? When he becomes frail, then he counts less in some way. I feel like that's a harmful message. The Journal of the American Geriatric Society has declared that words like the aged, elderly, and senior should not be used because they connote discrimination and certain negative stereotypes. If you look up those words, they simply mean a person who has been alive longer. When you cannot utter the words about a stage of life or a demographic characteristic, one thinks of, I am old enough to remember days where certain white heterosexual people would lower their voices when mentioning that somebody was gay or Black. If you can't say the words, that suggests that the category is not one you want to belong to. In this case, our only option is to die young, which doesn't seem very attractive to me. Geriatrics also tends to focus on the oldest and frailest, saying that there aren't enough of them. But imagine if we included more healthy aging, how many more people would be interested in the care of older patients? And actually, this has already been done. There is an organization called A4M, American Academy of Anti-Aging Medicine. And it has something like 30,000 members to the American Geriatric Society's 7,000 members. There is something about this that appeals to people, providers and patients alike. So why is academic medicine not doing this, particularly since this is a very .com area where people are paying hundreds, thousands, and tens of thousands of dollars often for snake oil. So we must focus on healthy aging. This market, 47.8 billion by 2027. The potential here to use this to fund other sorts of care. Much as I know UCSF cardiology has a concierge practice, which enables them to provide the same quality of care by paying, charging certain people, allows them to provide very good care to people without resources. This may not be the best approach, but it might be a not bad temporary approach. Also on the subject of deprescribing and drugs aren't always the answer. This from David Newman of Number Needed to Treat. If you look at the benefits of statins, number needed to treat over 5 years, 104, you're going to give, one person in 50 diabetes. And you have to treat 83 people to prevent a fatality and 39 to prevent a non-fatal MI. But if you look at a Mediterranean diet, the number needed to treat is smaller in a time frame that is 1/5 the time frame. No side effects, except for better health, better sleep, and the numbers needed to treat are better. So, are we making the right approach? Tech offers huge opportunities for self-monitoring, for putting control back into older people, for relaying information in a way that's helpful to us. But it also has pitfalls. And I think in care, if we could save caregivers back pain, and risk of injury, that would be great. But do we really all want to get older in a world where we only deal with computers because all the other humans have written us off? Not sure that's the best approach. Once upon a time, we used to say, the future of elder care is AI, and seniors have been lost in the digital revolution. Humans aren't going to have to care for old people. Won't that be great? And, old people are anti-tech. I mean, just these mixed negative messages. And what we're seeing now is, devices that help. And part of that, when you see tech that doesn't work, think about it. Is that really age, or is it generations, a non-digital native? Or is it that the tech is age oblivious? Among my middle-aged friends, we sometimes mistype, and that has to do with changes in the eyes and things like that. So if you're thinking the same device or the same size device works for all people, that might be a mistake at the level of conceptualization. And we also saw that when the right incentives were present, unfortunately, pandemic tech usage skyrocketed. Smart adult diaper makes sense. Smart tampon, not so much, right? Because tampons are us and diapers are them. We also had a talk some years ago from a major tech startup talking about how much they were going to help people over age 50 with their adult diapers. So you need to have a sense of your audience. And the number one most useful device listed by older people is actually the smartphone, and increasing this smartwatch. So I think another area to keep your eye on is something that might be labeled elder health tech, but I also think it requires compassionate and informed clinicians so that it is less paternalistic and more enabling. Finally, this is Peter Singer, one of the most famous ethicists on the planet, and he asked, is age discrimination acceptable? And answered that it is very different from discrimination on the basis of, say, race. Everyone who is old was once young, and some people have a greater chance of becoming old than others. No one who is Black was ever white, and there is no impartial race-neutral perspective from which we can all see that it is in everyone's interest to save the lives of white people rather than Black people. So ageism is different, and the justification for ageism is limited. It does not extend to forms of age bias discrimination that are not life-saving. So if you're in Italy and the pandemic has started and you only have a certain number of ventilators, it probably makes sense to put people in their 20s on it and not people in their 90s. But if you have somebody in their 50s with grave, with a very low life expectancy and metastatic cancer, and somebody in their 70s without that, it might make sense to give the ventilator to the person in their 70s. But he says, there is no argument ethically for giving preference in employment to younger people when older people can do the job as well. And I would extend that to say there is no preference, there is no argument for giving preference in healthcare to younger people when it might benefit older people equally. So when it comes to age, think about what you want for yourself and your family. Recognize that we are all ageist and we all have internalized ageism and that we can do better. And with that, I will stop. Thank you for your attention.
Thank you so much, Louise, for a comprehensive overview of many, many things. I think one thing to point out, when we started, I remember them saying, oh, there are less than 10,000 board certified geriatricians in the United States, and there's a silver tsunami coming in 2010. And so what can we do? And then coming to Stanford in 2021, I decided to look up the statistic, and we're less than 7,000 board certified geriatricians. So I think, for people in our section here, these topics are very, very much what we deal with every day. And one thing that we can point to a lot is ageism. So I'm glad you finished with that slide. But one thing that is clear is that ageism within our community as medical doctors, and probably even geriatricians, I'm an ageist as well. What are you aware of across the nation as you've been going through different places in terms of training the trainers or training even the trainees in medicine about their own implicit biases with aging? Are you aware of any programs? Teaching?
Yeah, well, sometimes in the social behavioral sciences curriculum, they do say Harvard's implicit bias tests. They tend to not include age. Some do, but many don't. But a lot of schools have also found that it just makes people angry. And you have to have the right small group leaders to really discuss this well. So it's a level of training where you have to train the group leaders so that they handle the sensitive topics in a way that is that moves the conversation forward instead of leaving people angry and frustrated. I think age bias is less included. And I guess one thing I said throughout the talk is that I think intersectionality is vital. Few of us have a single identity. I would wager to say actually none of us have a single identity. And you saw in pandemic also, I think, it was too long anyway, but I might have referenced this where it was like, highest risk are people of color, highest risk are old people. Well, actually the highest risk was old people of color. You can be both. And I think that if we have a system that you have to prioritize, like some people are more likely to grow old than others. So if you have to prioritize, and resources are often the reason for that, I think giving everyone an equal chance to grow old is a better place to start. But do we really have to go that way? And many of the structural unfairnesses, the sort of inequities in our system, hew across many lines. It's age, it's race, it's gender. So if we were to do a wholesale fix, I think really restructuring payment systems, that would address all these ills simultaneously. Actually practicing evidence-based medicine across the board such that you address disparities by, race, gender, and age would make a huge difference. So there are ways of approaching this consistent with other ventures already underway. But I feel like so much of it is sort of lip service or, and not that small steps aren't good, but this is a structural problem and it's going to require a structural solution, sort of like burnout.
Right. So we have one question in 1 minute. It's, can you comment on the lack of public health programs to deliver preventive care at home to homebound elderly, such as flu vaccine, pneumonia vaccine, and COVID vaccine?
Yeah, so I actually deployed with the San Francisco Department of Public Health and then with the state during pandemic because they didn't actually have anybody with any expertise. They had no way of collecting data. They don't know who is homebound. So probably the best way of doing that would be to make it part of home health services and adult day programs, but you would still then be missing the majority of people. Because of who gets those services, particularly the adult day programs, you would get a higher percentage of, Medi patients and underserved patients. So it's not a bad approach. But we have sort of universal childhood vaccination programs because it makes a difference. And actually, in terms of saving lives in this century, it makes at least as big a difference in older adults. But most public health agencies, I'm just working with some students on reviews of that, will have subcategories for, for children or for people from certain other populations, but they only infrequently have something for older adults. And when they do, it's almost always dementia. And if there's something else, there's falls. So again, if you were following the evidence, you would definitely be paying attention to vaccination. But right now, it's just luck if you live in a place with home care programs or, the bad luck of being hospitalized and requiring home health afterwards, then you might get your vaccines.
Oh, thank you so much. So I have a hard stop at 9. I don't know about you, Dr. Aronson, but Dr. Errol can take over if you have time to answer because more questions are flooding in. But I actually have to leave. Thank you so much.
Thank you. I have a patient too, but I told her I might be a few minutes late, so I can stay a couple more minutes.
Dr. Cato, maybe I'll just ask one. I know a few popped up here. Dr. Ash has the most upvoted one. I might ask that one, and then we can close so you can get to your patients too, if that's okay.
Sure.
I've been intrigued by the possibility of intergenerational matching to improve the lives of younger and older people, for example, foster grandparenting. How can we incorporate that into healthcare?
Such a good question. I mean, if we had a healthcare system, it would be incorporated because it would improve outcomes of both the older people and the younger people. And there's actually a tremendous literature on this already proven in the psychology literature, the sociology literatures. The problem is we kind of have a medical care system. So interventions like that, which don't involve, drugs or procedures and which prioritize outpatient settings over inpatient settings are not hugely supported. So I think that would be a terrific thing. The data on purpose and health in old age is really strong. Actually, there was a JAMA study maybe 2 years ago, and it showed that it was equally strong at age 19 and age 90, which I thought was like a really fascinating outcome. So having that sense of purpose, and you have different skills at different ages. So there have been a variety of programs like this. It lowers ageism. I mean, it's even something one might do more of in medical school so that people aren't like, oh, here's old people, let's take you to the nursing home. It would be like, here's old people, let's take you into the community because that's where, 95% of older people live. Could we have social prescribing the way they do more in Europe, where you would know your community resources better or have a social worker on your team so that you could then write a prescription and say, hey, look, I think for your social isolation, for your lack of sense of purpose, for your trouble sleeping because you're just sitting around the house all day, the thing for you would be a foster grandparenting situation or something like that. I think we could all just start doing social prescribing, although it's a little harder in the EMR than, I sort of think like, could we bring back those cute little pads for things like that and actually hand people something? That would be terrific.
Dr. Aronson, thank you so much. I want to first thank Dr. Cato for moderating, Drs. Martin and Harmon as well for helping organize this session and this special King Lectureship. And again, Dr. Aronson, you may see in the comments, and I'm getting other messages as well, what an amazing talk this was. We wish we had more time for questions, but but it's such an important topic. Especially thank you for mentioning what you did about nursing facilities as a hospitalist. I see that from a different perspective. It's not talked about enough, and I wish we had more time to talk about it. But most importantly, thank you so much for this really important talk today, and hopefully we can invite you back sometime in the future.
Right. Well, thanks for having me. It was a pleasure.
Everybody has a great rest of the day, and we'll
Bye.
see you next week. Thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.